Welcome and thank you for joining. My name is Linda Denude and I'm a health educator for community health at Atlantic Health System. Today's webinar, Understanding My Colorectal Health, is presented by Dr. Weiss. Before we begin, I have a few announcements. This webinar is being recorded. All participants are muted. If you have a question, please use the Q&A button and the chat for comments. We'll try to get through all questions at the end of the presentation. Are you or a loved one interested in smoking cessation? Atlantic Health System offers a free quit smoking program. This program includes an individual assessment, free nicotine replacement products, and 6 weekly group meetings to help you quit and stay smoke-free. There are multiple dates and times available, with groups available in person or virtually. For more information about these groups and other resources, or for additional dates and times, please call 1-844-472-8499. Okay, thank you. I'm now going to go ahead and turn it over to you, Dr. Weiss.
Okay, hi everybody. Good afternoon. And I want to just first, before I pull up my slides, I just want to congratulate everybody for joining the webinar today to show their concern and appreciation during this colon cancer awareness month, colon cancer prevention awareness month. So I'm going to now share my slides with you. Let me just pull that up. All right. Linda, can you see that?
Yes, perfect.
Okay, great. So, again, my name is Eliezer Weiss. I'm a gastroenterologist with the Atlantic Digestive Health Institute, part of Atlantic Medical Group. And today, we're going to discuss the topic of understanding my colorectal health. I have no disclosures. And basically, what I would like to discuss with all of you today, for the next 40 to 45 minutes or so, and hopefully we'll have some time for some questions at the end, is in general, we're going to discuss some basics of the colon and rectum as well, to kind of get an idea, make sure we're all on the same page and we know what we're discussing when we're discussing this vital organ. We're going to give a brief overview of colorectal cancer and why it's so important, why we have a whole month dedicated to its prevention. We're going to then go ahead and discuss some of the current recommended screening options that are available to prevent colon cancer or detect it early. And then at the end, we're going to spend some time discussing some future directions, goals, aspirations in the field of colon cancer prevention. So to start off with the basics of the colon, again, just to make sure I know that everybody here may have varying understandings of what the colon is and what we're referring to. So you can see here is a picture of basically our digestive organs that are in our abdomen, in our body. The colon and the rectum really are the last part of our digestive tract. So as you can see, I don't know if you could see, I think you could probably see my mouse moving here on the screen. As you can see here, coming down from the top is your esophagus. That's where you swallow. From your mouth, it goes into the esophagus, then your food will go into the stomach. And from the stomach then goes into this kind of wiggly thing in the middle here called the small intestine. The food will kind of go all around through that. It's very long, even though it's called the small intestine, it happens to be very long. From there, it then goes into this kind of thicker thing, which is called the colon. The colon is the same thing. It's synonymous with the large intestine. So you may hear those terms. That's really the same thing. And then we'll talk about what happens to it a little bit, your food when it goes to the colon. And then it goes through your colon all the way down here into your rectum and then out the bottom at the anus. You have also the liver and, behind this, you can get a little peek of the pancreas. Those are also involved in food digestion, but again, not something we're going to discuss today. Now, taking a little bit of a closer look at the colon here, the colon has different parts. So for anybody that's had a colonoscopy before, they may have seen the report that the doctor wrote, and they may reference these different parts of the colon. You have actually it's like this is somebody as if they're facing you, so this is the right side of the person and this is the left side. So here is the right colon, which is something called the cecum is a portion, another portion is the ascending colon because it's ascending, it goes up, then the transverse colon, which goes across, the descending colon, which goes down, the sigmoid colon, and then the rectum. Those are the different portions of the colon. Again, not that important to know, but you may see them kind of referenced on your colonoscopy reports if you have one. Now, what is the point of the colon? What does it do? Why do we have it? So basically, it's, as we mentioned, a part of the digestive system. It's a tube-like organ, kind of like a, if you can imagine, a flexible mobile tube that connects the small intestine on one side to the anus on the other. And what it does is, as the food goes through there, that you've eaten previously, it will remove water and some nutrients and electrolytes from the partially digested food. And then whatever doesn't get reabsorbed back into your body, that's really the extra, the unnecessary part of it, what we call stool or waste or feces, that moves through the colon, and the colon also serves as a storage container for that until it's time for it to leave the body through the anus. And that's essentially what the colon does and why it's there. Now, colorectal cancer, why are we talking so much about it? Well, we talk so much about it and we spend so much time on it because it's unfortunately very common and very serious. It's the fourth most common newly diagnosed cancer overall. This is of all types of cancer in the United States. As you can see on this chart, breast cancer, prostate cancer, lung cancer are a bit more common. However, even though it's only the fourth most common, which is a lot, but it's the fourth most common newly diagnosed cancer, it's the second most common cause of cancer death. So it disproportionately causes death when it is found, unfortunately. And it does account for more than 50% of GI-related cancers in the United States. That's why, it's as myself being a gastroenterologist, it's essentially one of the things that I spend most of my time doing is trying to prevent colon cancer. Looking at it another way, about 5% of the American population will eventually develop colorectal cancer. As you can see in this picture here, that's 1 in 20 people. And that means, another way of looking at it is about more than 6 million Americans that are alive today will die of this disease. So there are groups of people that are at higher risks than others, and that's important to know, although everybody should be aware of it and concerned with it. But men definitely are at higher risk than women. Black individuals and Native Americans are more likely to be diagnosed as well as to die, unfortunately, from colorectal cancer. And then the age makes a difference as well. So regarding polyps, which we'll discuss a little bit more in a moment, colon and rectal polyps are more common after the age of 45. And as we'll kind of reference, that is why the age for recommended initiation to begin screening is at 45, is because of that. However, colorectal cancer itself is highest, the rates in adults over 50. But we have been seeing, frighteningly, since the 1990s, there has been an increase in individuals that are 49 years old and younger. And that's why a few years ago, as I mentioned just before, the recommendations for screening, which used to be for 50-year-olds and above, have now been decreased in average risk individuals down to 45. Now, there are some symptoms that can come along and can lead to suspicion for colon cancer. Typically the most famous one is if you have bleeding, from your rectum, or if you see blood in your stool. That's obviously a famous one. A change in bowel habits, having pain or discomfort or inability to pass bowel movements when you feel as though you need to, lower abdominal cramping, gas pains, and then weight loss, unintentional. Obviously if you're trying to lose weight, that's a different thing. But if somebody's just kind of losing weight and they don't know why, these are all symptoms that certainly they don't mean you have colon cancer. So if anybody has any of these, don't get frightened, don't come away nervous, but they are certainly things that if they do arise, anew, it's something definitely to discuss with your doctor. Is it something that you should look into? But it's very important to be aware that both precancerous polyps as well as early colorectal cancer often have no symptoms at all. It may just completely be found incidentally with somebody that is completely unsuspecting that it was there. And it's very important to be aware of that, because typically when these cancers have no symptoms, they are often at earlier stages and it's easier to cure them. I'll show you a slide on that in a moment. And that's why, because it's more easily cured, that also will obviously increase your chance of survival. And there's many more options, of how to treat it and how to rid yourself of it when it's found at an early stage. So this key time of asymptomatic, when there's no symptoms, finding these polyps and cancers is very essential. As you see here, when the 5-year survival when cancer is found at a very early stage is more than 90%. That's very good. That means, the vast majority of the time, people will do very well when it's found at a very early stage. But the problem is that only about 40% of cases are found at this early stage. So that's another reason we're going to be discussing the idea of screening, which we'll discuss further, of finding cancers early on. So this is one more concept I want everybody to have in mind. I'm sure many of you have heard either in yourselves or in family members or on TV, whatever, this concept of polyps. So there's something called the Adenoma-Carcinoma Sequence, which means adenoma is kind of a type of polyp and carcinoma means cancer, which means you don't one day wake up usually and just have a cancer out of nowhere. That's not how it works. So typically what happens is, you can see here in this picture on the right, is you'll have some normal healthy colon. And then as time goes on, something starts to grow in there. This is kind of a change over time that you see here. And that's called a colon polyp, that this little bump that gets bigger and bigger over time progresses until the point that on the right here, it becomes cancer. That's called the Adenoma-Carcinoma Sequence. And what we're really trying to find are these polyps earlier on, because we don't want it to get to this cancer point. Now, again, even this sequence takes a very long time to happen. You can see in this slide, from when a tumor begins until it evolves and becomes a cancer, at times can be decades. So that gives us a big window in which to really screen and try to find colon cancer. And again, regarding when to start that, we don't start when somebody's born, the day they're born, of course, because the risk of them having colon cancer or even polyps at that time is very low. So again, that's why we use statistics and studies to see, at what age people certainly start to become at risk for polyps or for cancer. And as I mentioned before, the current recommendations are 45 years old to start checking for average risk individuals. We'll discuss what I mean by average risk momentarily. Now, when we talk about preventing cancer, there's a couple ways of doing this and a couple ways of thinking about it. So one way is, to kind of figure out what are the genetics that cause somebody to have cancer, various biologic issues or environmental factors that they encounter, and trying to intervene at that stage to prevent them from having cancer and developing cancer. And that's called primary prevention. So what are some things that are risk factors that cause people to develop cancer? Well, some of them are something, unfortunately, at this stage in time, there's nothing we can do about. There's nothing we can do about it. So for example, if somebody has a genetic predisposition, meaning their DNA, they have a family history, so they're predisposed to colon cancer, they have what's called a hereditary polyposis syndrome. It's a very complicated word, but it basically means that their genetics predispose them to colon cancer. If somebody has something called inflammatory bowel disease, you may have heard of that, Crohn's disease or ulcerative colitis, those patients, some of you may even have that. Some of these patients are people that are at higher risk for colon cancer. Or if somebody themselves has a history of polyps, so if any of you have ever had a colonoscopy and have polyps, your doctor may have told you to come back sooner for a repeat colonoscopy. And And again, this is because these are risk factors, and unfortunately, these are what we call non-modifiable risk factors. Right now, there's nothing we can do to change your family history, your genetics, the fact that you have inflammatory bowel disease, or the fact that you've had polyps. That just puts you at a higher risk. But there are what are called modifiable risk factors, certain things that place people at higher risk for colon cancer that we can do something about. So, for example, obesity, that places somebody at a higher risk for colon cancer. Diabetes, once you have diabetes, obviously there's not much you can do about it, although sometimes you may be on the borderline there. But if your doctor says you're at risk for developing diabetes unless you do A, B, and C, so you want to do A, B, and C because among other things that diabetes certainly will predispose you for, and that you can talk to your doctor about, whether it's heart disease, whether it's, various other, cancers, unfortunately, but colon cancer also you're at higher risk when you have diabetes. So you want to try to avoid that. Red or processed meat, again, limiting that in your diet, as that is a modifiable risk factor for colon cancer. Smoking, as we know, is a risk factor for many, many cancers. Alcohol and androgen deprivation therapy. Some people are on that, something Lupron, or people take for all different reasons. So again, before we move on to the next slide, so these are what we call modifiable risk factors. So again, taking steps to limit these or prevent these or remedy these issues will help prevent colon cancer. Now, another way of preventing or limiting or controlling colon cancer is, or really any cancer for that matter, is what's called secondary prevention. And that involves identifying things that are precancerous or early cancerous lesions, and then treating them quickly and in a very effective way. And that's what we call screening, where basically we're trying to find things that have already started to develop, but finding them early and dealing with them rapidly. This slide kind of gives a little bit of a deeper understanding of screening. So screening is something, when we talk about it, it's something that we apply to very large populations. So if we say that we need to do screening for colon cancer, it means everybody in the country, really, or in the world that's over 45 should be getting tested for or screened for colon cancer. There's something else which is called case finding, where we kind of look for specific things. If somebody's, let's say, blood counts, they're anemic, their blood counts are low, then they need to get checked and everything. But screening means irrespective of any symptoms or abnormalities they have, just checking everybody for something. And when do we do screening? Well, we do screening when we have something to screen for that is a major health problem, when we have an effective therapy to treat it, some good way to treat it, that if we find that there's actually something we can do about it, if we have a good test that helps us reliably find the issue that we're looking for, that is acceptable to both patients and physicians. So let's say, we had, just to make it, just to understand, if we had a wonderful screening test, let's say we had a great screening test for colon cancer, that we're going to cut everybody's stomachs open and then look, and then cut their colons open and then look in there if they have colon cancer. Certainly that's not going to be acceptable to people. So we're not going to do that as a screening test. So it has to be something that's acceptable, that's reasonable to do, to be a screening test, both, again, for the physician and the patients. And it has to be cost effective. There are patients that sometimes come in and say, well, why don't we just give every person in the country every test from head to toe for everything that they could do, and then we'll find anything that might be there. Because, again, that would be a burden that probably the healthcare system wouldn't be able to handle, and it wouldn't really be what's called cost effective. So all these are factors that come into play when the societies and the physicians make recommendations as to what screening tests are recommended. All of these factors, and all of these factors do apply and are true of colon cancer screening, meaning colon cancer is a major health problem. We have a good way to treat it. We have several good tests that are acceptable to both patients and physicians. and the screening tests have been found to be cost effective. That's why it applies to colon cancer screening. So what are the screening options that we have? Before I get to the specific screening options, I just want to show this slide to highlight the fact that it's important to realize that colon cancer screening really works. So this graph that we see here, where you see something that's very high going down, both in males and men and females and women, here we see that male incidence. Incidence means how many new cases of colon cancer are being diagnosed. That has gone down. And mortality, that means how many people are dying of colon cancer, that has gone down in the time since we've been screening for colon cancer. So we see that screening is really making a difference. So again, what are the recommended screening modalities? So this is a list here of the current recommended screening tests for colon cancer. Here it's bifurcated into two different types. We have what it's called the one-step approach, which is really the only one of the one-step approach is colonoscopy. Colonoscopy is called the one-step approach because it's a test where we can both examine, look for polyps and cancer, and in the case of polyps, treat it at the same time, and God forbid, in the case of colon cancer, we can take biopsies if needed at the same time to fully diagnose it. That's why that's called a one-step approach. Then we have various screening tests, which are what are called two-step approaches, and they include certain stool-based tests, which is one example is a fecal immunohistochemistry test, where we're basically testing the stool for blood. A multi-target stool DNA, where we test the stool for cancer or advanced polyp DNA. That's sort of if you've heard of the Cologuard, we'll talk more about that shortly. Those are some of the stool-based tests. We have what's called a flexible sigmoidoscopy. I'm going to explain all of these more in the coming slides. We have what's called a CT colonography and then a capsule colonoscopy. All of those are two-step approaches because, as we'll again show in the coming slides, if any of those come back positive, meaning they find anything, you need to then go ahead and go on to the next step of that two-step approach, that being always a colonoscopy. So another way of looking at these different recommended modalities for colon cancer screening is as per the most recent recommendations by the American Gastroenterological Association, the AGA recommendations. They group them into different tiers. So the first tier is the most highly recommended test for colon cancer screening, and that includes a colonoscopy, as well as an annual FIT exam. And I wrote here high quality colonoscopy. You can keep that in mind. I'm going to come back to that a little bit later in a few minutes. An annual FIT test, which is, again, the stool test for the blood. Those are the first tier tests, recommended tests for colon cancer screening. The second level, also recommended, but slightly lower. Those are generally recommended in patients who decline a colonoscopy or the FIT, the stool blood test. Those include a flexible sigmoidoscopy. Again, I'll explain these more in a bit. CT colonography, and the fecal DNA, FIT combined with fecal DNA. And then the lowest tier recommendation, but still recommended in patients who decline or for whatever reason might not be candidates for all of the above, is, as we mentioned before, something called a capsule colonoscopy. So let's talk more about these different modalities that we have for colon cancer screening. So colonoscopy, might be the most famous one. As you can see here in the picture, basically from your bottom, we put in a camera, and it inspects the entire length of your colon. We're able to look with this video camera lens over here throughout the entire colon, and we get a picture, as you see over here on the right. There's different parts to the front of this colonoscope. There's a light that allows us to see, and then there's what's called an instrument channel. This is where we put the, whether it's a biopsy forceps if we need to take a biopsy, or a snare, something that we use to take polyps out, and there's many different things we can do. And that's how we work the magic with the colonoscopy, how we do everything using this device. Now, the advantages of colonoscopy is that it's both diagnostic and therapeutic, meaning we can diagnose and treat at the same time. It can both detect cancers and polyps, which are precursors of cancer. And the nice thing about colonoscopy is if you do it and everything goes well, you don't need to do it again for a long time. Now, some of the disadvantages are, and this one we'll discuss again in a little bit, some significance of this is that it is operator dependent. You need to go to somebody who does a good job. If you go to somebody that doesn't do a good job, then it's not a very helpful test. You do require, as many of you I'm sure know, a preparation to cleanse yourself out and sedation to go to sleep during the procedure, which would require you to have an escort usually to bring you home. And there is a very small risk of complications, as with any procedure. There's always a risk. It is very low, less than 0.1%. Really, it's quite low. But you know, it is important to just be aware of that. This is what we call the FIT test, the stool test for blood. This is the one that we use nowadays. This is one example of a kit where you collect the stool in there and it gets tested for the blood. So what the advantages there obviously are that it's non-invasive. You just have to give some stool in it and check it there. There's obviously, at least with the FIT portion, assuming it's negative, no risk of complications. Of course, if it's positive, as we're going to mention, you do need a colonoscopy. So that would be the same. It can be done at home, and what's called programmatic screening is possible. So programmatic screening means organizations or health insurances, I think Medicare does this, or certain Medicares, they can send out these kits to many of their, sorry, my lights just went out. Here, 1 second. All right, sorry about that. They can send out these kits to many of the members of their either healthcare organization or insurance panel, and they can screen many people like this. Some of the disadvantages are that, as we said, if it's positive, you need a colonoscopy. It has to be done very frequently. It's every year you need to do these. You're less likely to find polyps. This is really looking for either very large polyps or more frequently cancer. So you're going to miss these very early polyps that colonoscopies would otherwise remove. And you do get false positives on these that will require you to at times get a colonoscopy, even though there's nothing there. There's another test called a flexible sigmoidoscopy. I have to say this isn't done very much anymore for screening for colon cancer. It's very similar, as you can see here in the picture, to a colonoscopy. Just instead of inspecting the entire colon, you just inspect the left side. It's slightly less invasive, as I said, because you don't go all the way in. There's a slightly lower risk of complications, and you can remove polyps. That's an advantage on the left side if you find any. But if you do find any polyps, then actually the recommendation is to go ahead and do a full colonoscopy. So you need to end up doing 2 procedures. It needs to be performed more frequently than colonoscopies. And there is a preparation. It's not exactly the same as a colonoscopy. Usually at least an enema you need to have for that. And as we said, a disadvantage is that you don't see the entire colon. Again, this is really not frequently performed that much anymore for colonoscopy, because for all intents and purposes, really you would require the same setup and usually probably the same prep as you would need for a colonoscopy, but it is a recommended, proven option for screening. There's another test which is called a CT colonography, or some people call it a virtual colonoscopy. It's basically where you get a CAT scan and they do a virtual reconstruction of your colon. So on the left here, you see what a regular CAT scan looks at, and then there's computer programming they use to kind of give a view as if almost you were doing a colonoscopy to look. See here, this little bump, that would maybe be concerning for a polyp. That this is kind of a virtual colonoscopy because you're not actually putting a camera inside, but you're examining the colon. So some of the advantages of this is that it is certainly less invasive than a colonoscopy. You don't need sedation for it, and there is a lower risk for complications than for a colonoscopy because you don't put the camera in. But there are many kind of drawbacks and reasons that this hasn't really taken off, even though it's been around for over a decade, almost 2 decades already. Number one, you have to do, similar to a colonoscopy, you have to do a bowel preparation. You oftentimes have false positives. Sometimes there might be a piece of stool left in the colon that might look like a polyp that might trigger somebody to get a colonoscopy. If it is positive, they need to get a colonoscopy, which again will require a second preparation. The other thing that happens actually is that often you might find other kind of unintended items on the CAT scan, which will lead to all different follow-up tests and people getting nervous and many other issues. So sometimes you don't want to start fishing for things if you're not looking for it. And the reason we find those is because you do actually a regular CAT scan for this. So you're not just looking at the colon, you're looking at the entire abdomen at that, on this test. Another issue is that there's an issue regarding availability. Not many radiologists are trained in this, and not many insurances cover it. And there is, of course, with this, although you're not doing colonoscopy, putting the camera all the way in, there's a risk of exposure to radiation if everybody's getting these CAT scans all the time to be screening for colon cancer. Another famous test that is becoming more popular is the DNA stool test, multi-target stool DNA. The famous one is called Cologuard. Cologuard actually also tests for blood besides just the DNA. An advantage is it's non-invasive. There's no risk of complications. It can be done at home, and it is better than just the blood stool for blood alone, in that it does have a little bit of a better ability to find polyps and not just cancers. But again, some of the disadvantages here are, again, if it's positive, you are going to need to do a second test, that being colonoscopy. It is more expensive than just testing for stool blood alone. And it's a little bit new, so they don't fully know how often these things need to be repeated. Is it every year, every 3 years? I think right now the recommendation for the Cologuard is every 3 years. And then there is a concern for over-testing. If, let's say, somebody has a positive stool test and then we do a colonoscopy and it's negative, which happens very often, how do we deal with that? What are we supposed to do about that? And then the last modality that I'm going to discuss is what's called the colon capsule. This is an interesting idea. Basically, we've had these types of capsules for the small intestine for many years because of its difficulty for us accessing that area. But this is a capsule that you swallow. You see on the ends here are cameras that are recording and sending to a box, a recording box, pictures from inside your colon. And then a GI can go back and look at those pictures and look for polyps. The advantages are that it's minimally invasive and it doesn't require sedation, and it can even be done at home. But again, it does require a bowel prep, and if you find anything, then you need to do a bowel prep again and do a colonoscopy. And again, this is a newer modality, so we don't fully know how often you need to repeat these. I want to just for a couple minutes discuss, there was some news that came out, I'm sure many of you may have seen, that there's some question of how beneficial colonoscopies are from a study that came out of Europe a few months ago, that potentially colonoscopies didn't reduce colon cancer deaths as much as we had thought. And this was based on a study, again, as I said, out of Europe. It's called the Nordic study that was written up in the New England Journal of Medicine. There's many critiques of the study that have been written up, and I just want to hit on a few points just so you understand why it's hard to really apply. There was again a lot of news here, but hard to really apply that to our circumstances in the United States. A few issues were, number one, the way that study was done. Essentially, they were checking to see the mortality benefit, meaning the amount that colon cancer screening with colonoscopy prevented people from dying in an overall population of people that were recommended to have colonoscopy, irrespective of whether or not they actually ended up having the colonoscopy. So therefore, if many people didn't have the colonoscopy that were recommended to do so, of course, the benefit of the colonoscopy in terms of saving people's lives would be diminished. And in fact, less than half of the people in the study that were recommended to undergo colonoscopy actually had it. So that certainly decreased the benefit, meaning if any individual is recommended to have a colonoscopy and they undergo it, then certainly there's going to be more of a likelihood that that's going to help, of course, save their lives. Another thing to be aware of is that in many of the countries that were, again, this study was not out of the United States, it was out of Europe, and unbelievably, many of these countries have not established as their standard of care to do screening colonoscopies. So a lot of them didn't have many of the much of the infrastructure in place, how to do it, how to get people in for the test, how to, all the different things when you come to doctors such as myself and other GIs, and we have you all set up for it, we get the prep ordered, we have you come in, it's a whole system we have in place. They didn't have those systems in place, and certainly that will decrease the benefit that they saw there. Another thing is that, again, it takes time when you remove polyps to see the benefit of how that will save lives, because as I showed you in the slides earlier on, polyps can grow for many, many years. So you oftentimes, if you remove polyps as opposed to not removing them, you might not realize that that's saving your lives until many, many years down the road. So again, maybe this study just wasn't looking for over a long enough period of time. And the last thing is that, again, in many of these countries, because they're not in the habit of doing screening colonoscopies, the endoscopists, basically the people that did the colonoscopies, as per the standards that we have in this country, and as per the statistics that were reported in the study, they didn't really meet the standards of care that we set as benchmarks. So they were not as good really as what we hold as a standard here in America. So certainly, as I mentioned earlier, when we say colonoscopy, it has to be a high quality colonoscopy, and that means that it's performed by a high quality gastroenterologist or endoscopist. And in those studies, they did not, many of the people performing the procedures did not meet that level. So that limited the benefit as well. So future directions and goals, I'm just going to discuss this briefly. Where are we going? What is some of the future of colon cancer screening? So this is an interesting thing. It's not really ready for prime time yet. It's potentially coming down the pipe. There was a study, I'm not going to get into all the nitty gritty and details of it, but the important point of this slide is that there was a study about whether or not there can be a blood test that can be done for colon cancer screening, and whether that might be able to, kind of be part of our armamentarium, our options, our list of potential screening options that I mentioned earlier. So this is a study that was presented at one of the big GI meetings last May, and there was some very, very, very positive preliminary results. So stay tuned. Imagine going to your primary care doctor and not even having to give a stool sample. Imagine him just being able to get with your, maybe your yearly blood test, the blood test to screen you for colon cancer. Again, certainly this would be a part of the two-step screening processes. Obviously, if this was positive, you still would have to have a colonoscopy. But this is something that is being researched, and may be something you might hear about more in several years to come. Another future direction is trying to get as many people screened as possible. So there was something a number of years ago, in the last decade, called the 80% by 2018 campaign that was launched by the National Colorectal Cancer Roundtable. That was their goal, was to get 80% of eligible people screened by 2018. They didn't exactly meet it. They kind of plateaued at 65%. But so then they went back and kind of assessed, why is that? Why were we plateauing? Why were we not able to meet the percentages that we had aimed for? So some of the barriers that we found was that there were that sometimes patients may have no usual source of care, meaning they may not have a primary care that's recommending them for it. Sometimes there can be insurance barriers. That incidentally has been something that the GI societies as a whole have been lobbying Congress for, especially for patients with Medicare and also Medicaid. It comes up as well to try to make sure that everyone has adequate coverage. Often the private insurance is filed from that. Lack of provider recommendation. We've been trying to educate providers, primary care providers, to recommend colonoscopies. There can be logistical factors, difficulty for patients to get to the procedure and getting home. There could be fear, lack of knowledge. Of course, that's what sessions such as this are trying to remedy. And unfortunately, as is often the case, many of these barriers were more prevalent in patients that had fewer financial resources, lower educational attainment, and racial ethnic minorities. So that is something that certainly we are aware of and trying to remedy. So what are we doing at Atlantic Medical Group in general? And in Atlantic Health, and even more general, and at the Atlantic Digestive Health Institute in particular. Well, again, as I said, we're having community outreach sessions such as these. We do have a program called the Direct Access Colon Cancer Screening Program, which is basically if somebody sees their primary care physician and their primary care provider thinks that they are an appropriate candidate for colon cancer screening, they can basically refer them directly to have screening, whether it's with a FIT test or a lot of times the Cologuard, or whether it's for colonoscopy very often, and they don't have to come see a GI for that, assuming that they pass a short questionnaire, that there's no other factors involved. But that's something to try that we do to try to streamline the process of referrals and having people not have to have extra appointments prior to getting a colonoscopy. We have what are called electronic medical record healthcare maintenance reminders, which is basically so that primary cares as well as other providers always remember to refer for colonoscopy. The EMR, the electronic medical records of each and every one of you, kind of remind us. They give us reminders when it's time for somebody to get their colon cancer screening. And then another thing we've done is we've tried to have increased location accessibility. We offer colon cancer screening at multiple different locations, whether it's in Morristown, whether it's in Bridgewater, whether it's in Rockaway, whether it's in Summit, as well as others. And we're trying to have more and more places that are available so that people will have ease of accessibility to get there, and there'll be less of a burden in that way. What can you do as as people similar to myself that are trying to avoid getting colon cancer? So it's important to eat a proper diet, which is high in fiber, low in fat, low in red or processed meat. Increase your physical activity, exercise, that helps. Decrease the alcohol intake, and of course, as we mentioned before, quitting smoking. And most importantly, in a sense, make sure to speak to your primary care provider about getting screened. And then when they make a recommendation, follow up with the recommendations. If they say it, then proceed with it and listen to your provider. This is a list here. We're not going to go through all of these, but just so you can see, these are commonly asked questions that many people ask. So don't be frightened to ask them if you have these questions. And anytime we would have anybody be set up for a colonoscopy, these are questions that our navigators and our schedulers are trained to answer. And if they can, we can always, answer them. And the only one that I'm going to answer, I'm just looking at the whole thing. Will it be painful or uncomfortable or painful? Now I'm just going to answer that. The answer is no, it's not. It's not uncomfortable or painful. You don't feel it when we do a colonoscopy. That's that. So in summary, the colon is an essential organ involved in proper functioning of the digestive system. Colon cancer is a common and preventable condition. Early detection of colon cancer improves outcomes, and screening for colon cancer is an essential component of routine medical care. Thank you very much for your time.
I do see several comments thanking you for this presentation. I'll be sure to share all comments with Dr. Weiss after this. Okay, we have another question. This person shared that they are a previous heavy drinker and part-time smoker. They had their first colonoscopy at age 58 with 2 benign polyps removed. They're now 64. Would you say they're overdue?
So yes, it's a good question. I would say you're definitely, it sounds like, in the window where you should follow up with your doctor and ask them. And the reason I say that is because there's several factors. Number one is that there are different types of polyps. So some polyps can be higher risk polyps based on either what we see under the microscope when we look at them, whereas others are lower. Some polyps can be larger, some are smaller, and depending on all those factors, the interval at which repeat is recommended can vary. Furthermore, to make things a little bit more complicated, but all of us in the field we're well appraised of it. There have been certain changes over the past few years in terms of recommendations for repeat intervals. So it would definitely be a good idea to follow up. Regarding follow-up intervals, just based on the fact that you have a history of alcohol use and that you're a smoker, I don't know that actually there's any specific recommendation changes for people just because they have those risk factors. That would probably be an interesting area of research to look at, but I have not seen any guidelines that recommend any closer follow-up as far as colonoscopy, specifically because of those two risk factors. But definitely, as I said, because of the polyps and various different types of polyps that might exist, once you're 6 years out, I definitely think it would be a good idea to speak to your doctor and say, oh, was I recommended to repeat this?
Okay, I don't see any other questions at this time. So I want to go ahead and thank you for joining us today. We kindly ask that you take a few minutes after today's webinar to complete the program survey. The link to the survey has been added to the chat for your convenience. And a special thank you to Dr. Weiss for dedicating your time and expertise today.
Sure, I'm happy to be with everybody. It was really nice.
If you have any additional questions or comments, you can send an email to communityhealth@atlantichealth.org, or you can call 1-844-472-8499. That concludes our webinar. Have a good day.
Okay, thank you.